Thank you very much. Next, we'll hear from Rebecca Ramsey, so across the country here to Oregon, who's the Director of Community Care at CareOregon, where she worked to develop and implement an innovative team-based care management program which targets some of the plan's highest risk members. Thank you.
Great. Hello, everyone. My name is Rebecca. It's a privilege to be here with all of you. And I have the honor of being the closer on this panel, so I'm hoping to keep you engaged for another 7.5 or so minutes. I hail from the misty forests of Oregon on the other coast, although with global warming we've had 93-degree days and I'm melting over there. CareOregon is a payer, and we have about 220,000 Medicaid lives and about 10,000 dual eligible lives, 10 or 11,000 I think now. And we're the member and founder of 4 coordinated care organizations, which is Oregon's Medicaid solution to ACOs. And I'm here to talk about a new care model. It's relatively new. It's about 4 years old for high needs, high cost patients that marries a non-traditional workforce with safety net primary care practices. The program is called the Health Resilience Program, and it uses master's level community outreach specialists paired with culturally specific peer support specialists and addiction recovery mentors to work deeply with the practice's highest risk, highest needs patients. The non-traditional staff are much less expensive than MDs, NPs, or RNs, so the program is actually relatively inexpensive. And they focus primarily on the social determinants of health, but they are embedded in practices, so they're part of the primary care team. And I do want to say also that this program came as 6 to 7 years after Oregon has been really involved in patient-centered medical home. We actually were one of the first states to implement team-based models of care in the safety net environment. So this program would not be as successful if it wasn't based on interdisciplinary primary care with integrated behavioral health, really good data and EMR, and advanced access for patients. I don't think that the program would be necessarily more cost effective if it relied on a primarily physician-based model. And I say that because the target population that we're serving, their risks are related to intergenerational poverty, racism, homelessness, lack of self-efficacy, and a lot of hopelessness related to a lot of childhood trauma, self-medication with substances, a lot of mental health disorders. Those things that another workforce might be better able to assist with. So the program began as a small prototype and was scaled up using CMMI innovation dollars, and I should have the CMMI disclaimer on my slides like everyone else did, but I forgot it. We currently have 40 plus staff, so it actually has gone to scale. We have 40 plus staff embedded across 25 or more clinics, supported by a housing case manager, a couple of triage coordinators, and clinical supervisors. HRP clients are the 10% that are spending the 50%, Medicaid and dual adults. They have 72% of the population has depression, 60% has substance use disorders, 25% mental health conditions, 30% unstable housing, and 75% have experienced childhood trauma. So that is by definition the largest common denominator in the population. So I want to talk a little bit about what I think the secret sauce is in this model. First and foremost is the workforce. So we have hired skilled behaviorists and peers with community outreach capacity and excellent engagement skills. They work 60 to 70% of their time they spend in the community, going to shelters, going to hospitals, going to park benches, going to SROs, wherever people are living their lives. They are trained in trauma-informed care, and they are learning trauma recovery interventions, things like seeking safety methods, EMDR, evidence-based trauma recovery interventions. They have great clinical supervision provided by behavioral health clinicians, as well as dotted line supervision from a primary care champion. It's payer funded and administered. So CareOregon actually pays the salaries of the individuals and provides a lot of the infrastructure, but they're perceived and they operate as part of the delivery system. Very much, I mean, the primary care providers believe that they are as much part of their care team as anyone else on the care team. And they communicate that in their actions. So it's a strong culture of team-based care. And then we have a strong community of practice that facilitates learning and rapid process improvement. The 40-plus team comes together every Tuesday morning for case-based learning and huddling, where we do case presentations, and that's actually the strongest form of both clinical supervision, peer support around this really challenging population, and learning. The second element to our success, I believe, is that we're getting more and more connected to peers that have lived experience of either a mental health condition, a traumatic childhood, living in poverty, or an addiction issue. So those peers are a part of our community of practice, and they work for we subcontract with community-based organizations that actually know how to hire and train a peer workforce. The peers also allow us to build longer-term sustainability into our program because they are about a third the cost of a social worker and can spend much more time in the community with our clients. We have flexible patient support funds available. This is partly through our Medicaid waiver, and what this means is that in addition to making benefit exceptions to cover things that aren't traditionally covered by a Medicaid benefit, we also have the ability to encounter, you may have heard, I don't know if you've heard this before, but we have an air conditioner bill that our governor, or our previous governor, Dr. John Kitzhaber, put forward. The air conditioner bill is named the air conditioner bill because it allows payers to pay for things like air conditioners that do not have a CPT code for people who might have pulmonary or cardiac disease and would otherwise be in the ER. So it also pays for, non-covered DME, transportation to community centers, et cetera, things that typically can't be billed. And then we have very strong support from our delivery system. So in terms of outcomes, this is both a success and a challenge. So we have, for 2 years in a row now, shown almost exactly the same pre-post utilization outcomes, where we see a 35% reduction in non-maternity related inpatient admissions with a cohort of people that are enrolled in this program, and a 34% reduction in emergency department rates, an increase in outpatient behavioral health visit rates, and no change or a significant or a very slight change increase in primary care utilization. We have tried twice now with an independent evaluation team to do independent of CareOregon, so they work for a health system that is not CareOregon. We've tried to do a propensity match comparison group, and twice now have had a very difficult time identifying an appropriately matched control group using claims data. And I think a big part of that is that the selection criteria for our population are things that you don't find in claims data. But when I look at the decreases, these folks are in the hospital and the ER a lot, and when they're in the hospital, they generate a lot of cost. So their hospitalizations are a lot more expensive than a general Medicaid adult. So it doesn't take a lot of reduction in hospitalizations to see some sort of return. I actually cut our return in half. I said, okay, we know there's regression to the mean here. Let's take 50% of that and see what the return is. And it was a 2-to-1 return. So we're going back at this comparison group thing again. We have very high provider and care team satisfaction. In fact, across 125 responses, we had an average satisfaction rate of 9.4 on a scale of 0 to 10. And then we do have emerging data from patient surveys that we're seeing improvements in health-related quality of life and patient experience. So what's worked? The CMMI Innovation Awards subsidized a ton of learning and development. Without that, we would be nowhere near where we are now, and it allowed us to actually take a pause and go slow to go fast, so we were able to really learn and build the workforce capabilities, a web-based registry system, data and tracking that was really valuable. Again, the competencies of the particular staff that we hired, I just can't say enough. We use a behavioral interviewing technique because you can't find what we're looking for on a resume. The integration with peers, the delivery system and payer collaboration, and a lot of process measure monitoring. Our challenges have been outcomes evaluation, as I talked about before, and the fact that we are in a multi-payer environment. So in our FQHCs and safety net practices, we are a big payer for them, but we're not the only payer. One of our successes has been that we actually have a competitive payer, Medicaid payer, in our market who's now paying CareOregon to administer this program in their clinics. So that's the first, and we're hoping that we can increase that. We actually only have probably 1 to 2 other additional large significant competitor payers that we would want to integrate with to make it easier on the delivery system. We do have financial sustainability, so the program is being sustained by CareOregon and by this other payer at the tune of about $3.5 million per year. My advice and tips for others would be that I don't believe a care management paradigm is necessary or is sufficient. It's necessary but not sufficient for Medicaid high utilizing adults. I think we need to think beyond sort of care managing people back to a stable state, but we need to think more about a recovery model and the fact that a lot of these individuals have had extremely difficult lives for 20, 30 plus years, and we're not going to just fix them with a 6 to 9 month care management intervention. We need to bring in more non-traditional roles, especially peers. We're now in the process of contracting with an organization called the Iron Tribe. As an example, the Iron Tribe is a group of peers that have been incarcerated and are now out and are helping other people when they come out of the jail system. And then finally, I think community activation is probably our ultimate platform. I know my colleague Linda Dunbar is in the audience, and she is running another program using CMMI Innovation Awards where they use neighborhood navigators in the really difficult areas around Baltimore. And we're really looking at how can we find community residents and community members who can help us support activation within the communities that we serve. And that's it. Thank you.
Great. Let's thank the panel.